okay? Central ray is still going to be directed at the base of the third metatarsal. All right. By the way,
The third metatarsal.
What's that?
It's not on the third metatarsal, the central ray over there, on the picture. On the other one,
here,
on the actual.
On the actual,
I mean,
on the girl laying down,
It's
on the actual patient.
actual patient.
See where it's at, the central ray is on the current ankle.
like in the medial.
It looks like, yeah, it looks like it's going towards the ankle a little bit. Again, it's point of view. It's how we're looking at the image. So it may be, it's probably just the way we are looking at this particular image shows that it's probably not in the right spot. And that is okay.
Third metacarpal.
Okay, go by what it says here. Oh, so here's the by the way. When you're shielding your patient, what is the minimum requirement for gonadal shielding?
0.5 millimeters?
0.5
Millimeters of lead.
millimeters of lead or equivalent. Do you guys understand what equivalent means? What it means is that shielding, there are other materials that are used for shielding other than lead that are more lightweight. Okay, when we say equivalent, we can use material that has the same attenuating abilities as 0.5 millimeters of lead, which means I can use aluminum, I can use stainless steel, I can use cotton, I can use rubber, as long as it has the same attenuating properties as 0.5 millimeters of lead. Does that make sense?
Mm-hmm.
Okay. So gonadal shielding is 0.5 millimeters of lead or equivalent. The aprons that we use, the aprons that are hanging in our rooms, is that 0.5 millimeters of lead.
I think it's different.
It's only half the amount, 0.25. Yeah, it's only 0.25. Why? Because that shield is to protect us from scatter radiation, which has less intensity.
That's
than
for
that
us,
of the
right?
primary
It's
beam.
not,
That's for us.
it's not for the direct beam.
Okay? So, this is one of the biggest mistakes that I see technologists do, is they use the lead apron to shield their patients. It's only 0.25. Okay? So when you're going to shield your patient, you make sure it's gonadal shielding. Not protective aprons or protective shielding that we use as technologists. It has to be gonadal shielding. Okay? It's probably happening to your kid, right?
I don't know.
Oh.
I just had a question.
Yeah.
For the shielding, after a long period of time,
Mhm.
does it become less effective? Does it break down?
It doesn't become less effective. What happens is that from poor handling, poor storage, okay, crumpling up, throwing it on the table when you're done, it'll bend,
Something we've all done.
it'll crack. So the material actually, it doesn't become less effective, it becomes less effective by the poor handling of technologists.
So structurally it becomes
As long
less.
as
Structurally,
you
it
take
starts to
care
break
of
down.
It
Huh?
should just last. It'll always.
Right, if you take care of the lead, it should last. So, going back to what you're saying, we do a quality assurance exam on our aprons where we lay them under fluoroscopy and we do a visual check under x-rays to see if there's any pitting or cracking of the material. And if there is, then we get rid of it. Yeah.
Just patch it up.
Yeah.
Oh, duct tape.
Duct tape. Duct tape fixes everything.
As long as it's equivalent, right?
Yeah. All right, true lateral, okay? So lateral of foot, we're gonna have them frog leg their leg out, okay? They're gonna be frog leg, and it's a medial lateral projection because you're entering the medial aspect or medial surface of the foot and exiting the lateral, okay? In doing so, you may have to put a support or bolster under your knee, because what we're trying to do is we're trying to get the foot in a true lateral projection, like this, true lateral position. If they put their leg all the way down, there might be a slight obliquity of the foot, so we're going to prop up their knee to get it in a true lateral. And what we're doing here to make sure this is a true lateral is we're looking at the plantar surface of the foot. Okay, we're looking at the plantar surface of the foot and making sure that it's perpendicular to the image receptor. Okay? So in a true lateral projection, the central ray is going to be directed at the base of the third metatarsal. Third metatarsal. But as I'm going to tell you guys, when you're practicing and role playing, what do I always say?
Put the part in the middle.
Get the part in the middle of your field. Just get the part in the middle of the field. Now, you want to include all the way from your heel to your toe, and you also want to include the distal third, this distal third of your tib fib. You know what I mean by tib fib, right? Okay. So the lower third of your tib fib.
So it looks like the IR is kind of angled, or is it?
Yeah, the angle that's so that it's matching the length of the foot. And you guys can do that too.
Okay.
Yeah, so you can angle the tube to match the length of the foot. Is there anything wrong with this image?
It's not collimated?
Well, is it, okay, it has to do with collimation.
The shadow of the toes are.
The shadow of the toe. Are we cutting something off?
Mhm.
We're gonna cut something off. So they need to open it up a little bit more to include the toes. Or move the foot to include the toes. So I can move the foot back or open up the collimator just a little bit more to include the toe. Okay? But if you're moving the foot back, make sure you're not clipping off the heel. Okay, here's the alternate, which is the lateral medial lateral foot. Not common, but again, if the doctors request that, then that's what we're going to do. Why would we do something like this? Okay, remember, if there is an area of interest, we're trying to get that area of interest as close to the image receptor as possible. So this is for, if we're looking at the medial aspect of the foot, we're getting closer to the image receptor for better detail. That's the only reason why you would do that, okay? But rarely is this done. Look how uncomfortable that it looks, okay? Open up the collimator to, again, include the distal part of the tib fib, a third of the tib fib, okay? So the entire foot should be visualized. The tibio-talar joint is demonstrated. The metatarsals are going to be superimposed with optimal exposure factors. All right, Katie.
Yeah.
There it is. Okay. So this is one of the projections and views that would be used to evaluate the arches of the foot. So this is AP and lateral weight bearing. Here it shows abnormalities of the longitudinal arches and structural injuries to the ligaments, like a Liz Frank injury. Liz Frank injury has to do with the separation of the, let me see if I can get you a foot. Okay, so Liz Frank's usually occurs somewhere here at the base of the metatarsals, and there is a separation. The separation of this area here, also causing injury to those ligaments. That's a Liz Frank's injury.
Is it always between the second and third metatarsal?
No, it can be any one of those, but it usually happens at the base of the metatarsals. Okay. So in this particular projection, the patient is going to be standing up. It is weight bearing. We do it bilaterally. So you want to include both feet, both foots, okay. Both feet on the image receptor, say collimate to include both. And we are going to direct our central ray approximately, again, 10 to 15 degrees towards the heel. But we're not physically directing our central ray on the foot. We're going to be between the foot at the level of the base of the metatarsals. Why are we elevating the foot? Why can't the foot be at the same level of the edge of the image receptor?
You get in the center of the IR.
Okay. Guys, remember the divergent beam? If the foot was at the same level as the edge of the cassette, the divergence of the beam is going to go throw the foot off the image receptor. So we elevate them. All right? So with a horizontal beam, we have a block that we use to elevate them. You're going to do this one at a time. Okay, it's just like a lateral foot. Okay, you're going to center at the base of the metatarsal to include both toes and the heel. And again, we're evaluating the longitudinal arches of the foot. Also done bilaterally. Okay? Why do we do it bilaterally?
See if they're the same.
Okay, yeah, for comparison. For comparison, okay. Because you're doing both feet, make sure that you are using your the correct anatomical markers. Okay. All right, so bilateral feet are both demonstrated, phalanges and metatarsals, very similar to that, the criteria of your APs and your lateral foot, same criteria, okay? Any questions? Okay, the calcaneus. The calcaneus, two projections. First one here is the plantodorsal or axial heel, plantodorsal or axial heel. Remember, your heel is superimposed by other structures, so for us to get a true AP, we're going to shoot it from the bottom up, or bottom back. Place the patient flat on the table, heel on the image receptor. You need complete dorsiflexion of the foot. So you have to have complete dorsiflexion of the foot with the toes pointing upwards. Avoiding any rotation of the foot medially or laterally. It has to be pointed straight up. So the foot has to be perpendicular with the image receptor with dorsiflexion. You're going to use an angulation of 40 degrees cephalad, okay? Cephalad. And central ray is at the base of the third metatarsal to emerge on the backside between your tibia and your fibula. It's talking about here your malleoli. Okay? Now, question is, when you're looking at this, well, here's the heel. Why isn't the heel here in the middle of the image receptor? Why is it over here at the edge of the image receptor?
Because the angle's going to push it back.
Again, because of the angle, it's gonna throw the image back towards this edge of the image receptor. So when placing the heel on the image receptor, place it towards the bottom edge. It will project it towards, once you take the x-ray, it's going to project the heel towards the middle of your image receptor. Like so, okay? Now, I was reviewing the slides yesterday, and I think it was also mislabeled. I think you guys have here cuboid. Okay, it's not cuboid, that's your fibula. Okay, so change that. So this is pointing to the fibula. Your cuboid, I don't know why I said cuboid. The cuboid is up here somewhere, which you can't see because of the dense part of the foot. Okay. So now we have here the entire calcaneus is visualized with no rotation. This view is also very good in demonstrating the tuberosity of the fifth. Okay. If you have a good penetrated radiograph, you should also be able to see the talocalcaneal joint. Okay, but it has to be well penetrated, otherwise you can't see that joint space. Okay, and then the one bone that protrudes off to the side is your sustentaculum tali. Okay, any questions here? Okay, so did you guys fix this?
Mhm.
Okay. It's not the cuboid, it's the fibula. All right, lateral heel, medial lateral projection. We're only looking at the heel, so you don't need to open up your collimator as, you don't need to open it to the size of the image receptor, just the heel. But You want to collimate it to include what's anterior to the heel, okay, and what's superior to the heel. So include your ankle joints and also parts of the tarsal bones, other tarsal bones. Central ray is going to be directed 1 inch just below the medial malleolus. So again, open up your collimator to include your ankle joint, and then parts of your other tarsal bones. All right. Any questions here? All right, ankle. Routine views for ankle is going to be AP. The AP mortise is generally a special view. It's not part of the routine. And then you have your oblique and your lateral. So in performing the AP ankle, you're going to have dorsiflexion of the foot. Now, not everybody can do a dorsiflexion, but you want to get the toes upright as much as possible. You're going to rotate your foot so that it's completely perpendicular with the image receptor. Not like this, toes pointed up for a true AP. Central ray is going to be directed between the 2 malleoli. True malleoli. Who's back there? Who's the one with the hat? Jason, can you grab me a foot? No, grab Alex's foot. No, I'm just kidding. No, grab me a foot.
Not if he doesn't have a pedicure.
Oh, you got it? I thought he was going to go and grab his foot for real. That'll be fine, yeah. Thank you. Good. All right. So when we're taking x-rays, remember there's a difference between taking an x-ray of a foot and taking an x-ray of an ankle. This is not the proper way to take an x-ray of the ankle, because your ankle is perpendicular to the Whoa.
He's okay.
That'll shuffle.
Okay, so you can't take an ankle this way. This is how you would do a foot, okay? To do an ankle, you don't do it like this, you do it like this. Okay, this is a common mistake when you guys are doing your radiographs of your phantoms, okay? So this is the foot, plantar surface down. An ankle is plantar surface perpendicular to the image receptor, okay? So for the ankle, true AP, toes up. Central ray is going to be between the malleoli, okay? And, open up your collimator up and down to include the distal third of your tib fib. Okay, distal third of the tib fib. So the proximal half of the metatarsals are also going to be included, and then the medial and upper portion of the ankle joint are going to be demonstrated. Now in a true AP, remember in a true AP, there is going to be slight superimposition of the fibula with the tibia and the talus. Okay, slight superimposition. Okay? So it's only going to be the upper portion and the medial portion of the joint that's open. The upper portion and the medial portion that's open. Now if I wanted to open up that joint space, what am I going to do?
The mortise.
The mortise. And what was that angulation or rotation?
15.
Approximately what? 15 degrees,
15
right?
degrees.
Approximately 15 degrees, medial rotation. All right? So it's just a slight obliquity. The intermalleolar line is going to be parallel with the image receptor. Okay, that's what it's talking about here is when you properly rotate the foot about 15 degrees, the plane between these two ankles here should be parallel with the image receptor. Here's one malleoli, here's the
So
other.
it's almost like the epicondyles, right?
Yeah, exactly. So in a true AP, it's like this. We rotate it 15 degrees, it now becomes parallel with the image receptor. Okay? Hi.
We doing okay?
So now when you do so, yes, we're doing fine. So when you do that, now you're opening up the joint space, okay? Here, and you're opening up the joint space here. And now you see this socket-like image of the talus. That opens up the joint spaces, okay? Questions here. So if I hang up two AP projections of the ankle, would you be able to tell me which is true AP and which is mortise?
Mm-hmm.
Okay. All right. Left and left. Okay. 45-degree oblique foot. 45-degree oblique ankle. Sorry. 45-degree oblique ankle. So we know what 45 degrees is, right? Here's 90, here's 180, somewhere between here. Okay. 45 degrees. Same concept here. You're going to do a medial rotation. It's not external, it's medial. It's a medial rotation. And again, central ray is going to be directed between the malleoli. Your collimation should include a third, this distal third of your tib fib, and then also your metatarsals. Okay. Now, I want to go back here. There's a slight nuance. When you're doing the ankle, medial oblique ankle, you're dorsiflexing in the AP, right? When you're doing the oblique, now the foot may be relaxed. They don't keep that dorsiflexion. So you have the option, and there's nothing wrong with that. You can either keep it dorsiflex or you can have the foot in a relaxed position. Hey, you will see some variances. You'll see some variances out there with the text. Yes.
What are those black dots on their malleolus?
That's the malleolus. She's showing you where the malleolus is.
Okay.
Yeah.
I figured it was something to grab.
Oh no, they're just markers to show you where the malleolus is. Yes.
Does that really palpitate the malleolus to make sure our angles are correct?
Mm-hmm. No. What you're looking at, you're just looking here at the foot, the surface of the foot, putting the foot 45 degrees. Yeah, you're not really feeling or looking at the malleola, you're looking at the foot. Actually, that's a good question, okay? So you're putting the foot in a 45-degree angle. All right? Any questions here? All right, so what do we have going on here? So AP, slight superimposition, here and here. Mortise, open here and here, you see the full cup. And in a 45-degree angulation, you're gonna have complete opening of the, I forget what they call this. It's the
Tib fib joint?
Yeah, I'm trying to figure out. the
Tibial
correct name.
fibular joint?
Tibiofibular joint? Is it fibular tibular?
No, I think it's tibial.
Tibiofibular? Okay. We'll go with what Nick said. Okay. It's
it's
gonna
wrong,
open
it's
up
your
the
fault.
joint space.
I'll
It's
cut
gonna
that
open
part
up
out of the video.
If you get that
tibiofibular
wrong
joint.
on our quiz, it's your fault.
Yeah, we'll go with that. I like that. That sounds right.
The book says tibiofibular.
All right.
Good job, Nick.
All right. All right, any questions?
Would you be so lovely as to put those three images on a test and ask us which is which?
Could I be so lovely?
Oh, he's always lovely.
I would do something like that.
Maybe. I'll think about it.
He totally would.
Yeah, I'll think about it.
Yeah, he will.
Okay, lateral ankle. It is more easier to do a medial lateral, again, frog leg, knee out, than having to do the lateral medial. This is just harder to do. Okay? And when you do it this way, also what happens is that because you got one knee on top of the other, it elevates the proximal tib fib, causing this area to foreshorten, so you're not going to get a good visualization of that area. So medial lateral is the more easier position to do, okay? Now when you're doing a medial lateral, again, important that you dorsiflex the foot. Okay, so you're dorsiflexing the foot. You may or may not have to elevate the foot, because again, what we're looking at here is the plantar surface of the foot, making sure that it is perpendicular with the image receptor, no rotation. So the surface has to be perpendicular with the image receptor. Okay? Central ray centered to the medial malleolus. Okay, that's what the dot is there for. To show you where it is. Right? And I don't know if they're actually stickers. I think it's some kind of computer-generated dot. Doesn't matter. Okay, so central is directed to the medial malleolus. Now, if we were doing the alternate lateral medial, it's going to be centered where?
Lateral malleolus.
To the lateral malleolus. Okay. The entire talus and calcaneus are going to be visualized. Your entire talus and calcaneus is going to be visualized. The lateral malleolus is superimposed the posterior half of the tibia. The lateral malleolus is going to be superimposed over the tibia. It's also going to project where? More inferiorly. Very good, okay? Very good. Okay, which radiograph, A or B, is of higher quality?
A has more contrast.
B.
Okay, B is better, right? This is more contrasty, which is good, but it's not positioned properly. So you want dorsiflexion. And the criteria of doing an ankle is you also want to include the heel. So don't chop off the heel. This is going to be part of your collimation critique, is making sure that the heel was not cut off. Okay, so I like B. Although contrast-wise, I probably would have chosen A. But it's not positioned correctly. Okay. Does it look like it's oblique a little bit too? But you should have some superimposition here, right? And it's not, so this is not in a true lateral. All right. AP stress tests. You have, we're looking at the joint space of the mortise. So you will have somebody physically causing the stress, okay, to accomplish the eversion and eversion stress, valgus and varus.
Who would do that?
Who would do that? Not you.
I know, but who?
It's going to be either a technologist or the doctor.
So someone actually holds while they take.
Right. Now you guys know as students you're not supposed to hold. That's why I said that. It wouldn't be you. Did you guys know that?
Mhm.
Yeah.
No holding it when you're a student.
But once we're at tech, we would hold it?
Once you're a tech, then you would do it. Yes.
So even if they tell us, oh, hold this,
Pardon me?
even if they tell us, oh, hold this.
Go in and hold them.
Like at our
You-
clinical
you were
science,
out
they won't
there.
tell us to hold it, right?
Oh, no, they shouldn't. Yeah, they shouldn't tell you to hold
What
it.
do they do?
He's saying if
Yeah.
they do.
If they do, then you say you can't.
Oh, okay.
Yeah. Yeah, they know. They know they shouldn't be asking you. All right. So leaded gloves, causing the stress, take x-rays. And if you are the one holding, let's just say if you're a technician, you're the one holding, you're gonna wear leaded gloves, and what are you gonna do with your face?
Turn away.
You're gonna turn away, turn your neck away, okay, because we don't want all that scatter hitting your eyes and your throat.
So this is to evaluate the joint spacing here?
Right. We're looking for any type of damage to the ligament area.
Oh.
Kind of like the AC joint.
Oh, okay.
So there may not be any fracture, but there may be a separation, and we need to cause stress to it to see if there's any type of separation of those joints. Okay? Now again, if a patient can't do it, they can't do it, so you shouldn't be causing unwanted stress. The doctor will evaluate the physician, the patient, to see if they are candidates for performing these type of procedures. Okay. Now, with that said, they don't do a lot of these in X-ray anymore. Where do you think it's done? I mean, if we're looking at the ligaments, the tendons, it's either going to be done CT or MRI. We wouldn't do something like this. But remember the insurance game. They're going to do something like this first before they would do more of the advanced studies. Okay. So AP ankle with neutral position. Here we have eversion. Eversion, this is towards the lateral side. No damage to the medial ligament is indicated. Here, inversion, change in joint and rupture of lateral ligaments are demonstrated by where the arrow is pointing. So there is an obvious separation in that area. Okay? All right, we're done.